Good afternoon, everyone. Welcome to the fifth session of Confidence in Managing Emergencies. What we're going to be studying today is arterial blood gas analysis and basically trying to simplify how it works. And as interns, I'm sure all of you will have to do multiple ABGs of various patients and work in ICUs and things like that. So it's always better to understand what you're doing the investigation for and what the results are. So interpretation of those results is something you need to know how to do as interns, and not just there. Also, when you start working independently, if you ever get patients who are referred to you from higher centers, or who've been admitted previously, they'll have these ABG reports that you should know, and you should be able to assess if they require further ICU management or not. So this is a very important part of emergency care. So we'll start. Before we start, I want to know how many of you have done an ABG? How many of you have done the collection of an ABG? You can put a yes or no in the chat. Nobody has done an ABG. Have you seen someone doing an ABG? Okay, Tarun has done it. Aarti has done it. Okay. So I'm getting quite a few yeses. So this is good, the fact that you've done it. And I'm sure it wasn't very easy when you were starting to learn how to do it. So let's see if we can make it a little easier. Okay. So we'll be covering what ABG is, the interpretation, and a few cases so that you can understand how all the information ties together. Okay. Before we begin, you have to start at the basic. So the basic of ABG is you need to understand how homeostasis in your body is maintained. Your body is made up of certain acids and bases that are generated through metabolism. Basically, jo khana khate hum, the diet that we take, that gets broken down into certain acids and bases. The metabolites in the liver are acidic. Then how these acids and bases are formed is through these processes. But your body has to get rid of them, right? Your body tries to maintain homeostasis. It tries to maintain a balance between these two components. So how we get rid of the acids and the excess bases is by two methods, majorly. We have the kidneys that eliminate non-volatile acids, and we have the lungs. We also have another buffer system. Now, these methods of getting rid of these acids and neutralizing these acids and bases is called buffers. So your buffering system is your lung, your kidney, and the buffer present in your blood itself. So there are these components that maintain your acid-base balance. So all extracellular fluid pH needs to be between 7.35 and 7.45, which is your normal body pH range. Your body works very hard to make sure that it stays between this range. Whenever it goes above or below these values, that means you're going into acidosis or alkalosis. Okay, so the basic thing to understand is acid ban raha hai, तो उसको कॉम्पेट न्यूट्रलाइज करना है बेस डाल के, बेस ज्यादा बन रहा है तो उसको न्यूट्रलाइज करना है एसिड डाल के, बिकॉज हमें होम्योस्टेसिस चाहिए. This is the essential fundamental of entire ABG, of the entire what seems like a very complicated set of values that they give you. But the funda is this: acid hai, base डालना है, base है, acid डालना है. ठीक है? Now, the basis of arterial gas analysis, arterial blood gas analysis is pH. What we discussed before, when you're maintaining homeostasis, is you're maintaining the pH of the body. Now, how we determine the pH of any equation or any liquid is using the Henderson-Hasselbalch equation. Now I'm sure 11th में भी ये पढ़ाया था, 10th में भी पढ़ा था, 10th 11th में. This equation is very important in chemistry, especially in biochemistry, because your body is made up of different fluids and electrolytes and molecules and components. All of these have different acidic values. All of these have different basic values, different pH values. तो वो pH को neutralize करना होता है आपको. Can anybody tell me what the pH scale ranges from? What is the pH scale maximum and minimum values?
0 to 14.
Very good. So your pH scale ranges from 0 to 14, with 7 being neutral, right? And if you go towards 0, that means you're getting more acidic. If you go towards 14, you're getting more base. So when your pH needs to be maintained and it needs to be calculated, it's according to this equation. This is the only equation you need to somewhat understand to understand acid-base balance. What it tries to tell you essentially is, even if you don't remember the equation, it tries to tell you the relationship between your pH and your acidic and base composition. So your pH and pOH along with your constant, your pKa is a constant. You don't need to know the values, it's not important. As long as you know that there is a basis to the interpretation that you're doing, it's fine. Okay, so this is what your homeostasis is, and this is what pH is. Now, what is ABG? ABG is an investigation that we do to determine the oxygenation of a patient, the ventilation, basically if the oxygen is reaching the body, if they're able to ventilate, breathe properly. We assess respiratory function and we determine acid-base balance. So it's a very important investigation that you send that does multiple things at once, if you know how to interpret it correctly. Okay. Now, what are the sites for arterial blood collection? You have radial, which is most commonly used, brachial, femoral, dorsalis pedis, and posterior tibial. I have personally never seen dorsalis pedis and posterior tibial used, but I'm sure at some point in the ICU, when you run out of sites where you can do an ABG, they would need to do a dorsalis pedis or posterior tibial collection. Why do we prefer radial? Can anyone tell me?
It's more superficial, na ma'am?
Exactly. So it's more superficial. The access is easier. Patient is more comfortable. If you try to do a femoral, it's more uncomfortable for the patient, so it becomes difficult to do. Again, with femoral collection, the sterility maintaining sterility is difficult. So because of all of these reasons, we usually go with radial. Now the issue is radial is sometimes difficult to do collections from, because the perfusion might be less. If a patient has come with severe hypotension and you need to do an ABG, एक तो आएगा ही नहीं, पल्स ही नहीं फील होगा. अगर पेरिफेरल पल्स नहीं फील हो रहा है, तो that's when we start moving towards brachial and femoral. Personally, what I have found is femoral is the easiest to do because the pulse is very easy to find. So as soon as you find the pulse, you know where to do the collection from, right? But we still prefer radial above the other two. Okay, let's see how it's done. Did you guys hear what I explained about the preparation, the equipment required?
Yes.
Okay, great. So this is the prep, and he's going to do a test to check the perfusion of the hand. Now, this is something that is not done very commonly here, but it's a very effective test usually. Okay, now he's palpating for the radial artery. Once he's found it, he's going to clean the site. They'll do sterilization, and then they'll give anesthesia. Now, this is a very important thing. In your needle, when you're doing an ABG, you have to make sure there's no residual heparin, because that heparin can give you false results. You will get the electrolytes, that readings that you get in your ABG will not be appropriate because of the heparin in the syringe. So whenever you're preparing the heparin syringes also, this is something we were taught in the ICU, is that make sure all the heparin comes out from the syringe. All that is needed is enough to coat the syringe, not anything extra. Okay, did you guys understand what is happening in the video? We'll just go over this part again. So in an ABG, the difference between your normal blood collection, did you guys see the entire video? Was it visible? Otherwise, I'll play it from the beginning. We have the equipment, palpation, anesthesia, and in ABG, the blood, if it's arterial, will fill in the syringe on its own, right? This is difficult to get in a radial artery because itna arterial blood ka pressure usually nahi hota hai, especially if the patient is hypotensive, if they're dehydrated. But if you do femoral, especially, and this was shown to me by a neurosurgery resident, he was doing the ABG and he took a femoral puncture and he's like, automatically wo bharna chahiye. Only then it is a proper arterial sample because the pressure in the femoral artery is that much, right? And can anyone tell me how do you identify arterial blood as compared to venous blood?
Where arterial blood will be more reddish than venous blood.
Right. Arterial blood is bright red as compared to venous blood. So when you do the collection also, even in the syringe itself, you can see that it's bright red blood. And once you've collected it, make sure to get rid of any air bubbles on top. Because again, if you don't, when the report comes, the oxygenation will be much higher than the actual patient's blood oxygen levels. Okay. Now femoral. Okay. So the only thing I wanted you okay, so the only thing I want you to understand the difference between a radial and a femoral ABG. The operator. Is this video audible? Okay. What you need to understand is you can see how the blood is filling on its own. And what they've done in femoral is they've gone on a 90-degree angle. They've gone perpendicular to the skin directly and deep inside because your femoral artery is placed much deeper as compared to your radial or your brachial artery, right? So this is something you need to understand in a femoral ABG, that the direction and the depth in which you take a femoral ABG is different from a radial ABG. Even your needle is different. Do we necessarily administer anesthetic before? Yeah. So ABG is a painful process. Ideally, you should give anesthesia when collecting an ABG. But we don't do that because in government setups, we don't have enough availability of materials. But you can collect it without anesthesia also. Again, when you're giving anesthesia, it becomes easier to do the collection. Because if you're giving an anesthetic, the patient usually moves when they feel pain, right? So तुम्हारा collection नहीं आता है. If the patient moves even a little, you lose your artery. So it will be more difficult to do your collection. So you can give an anesthesia and then do the collection as well if you have it available. Again, now for femoral, again, very painful for the patient. So if you have anesthesia, it's better to administer it. Okay, are we clear with the method of how exactly we do it, how we do the collection? Okay. Another tip that I got during my ICU posting and medicine was the hand position when you're doing a radial ABG. You can keep a bottle of NS below it. So your wrist is extended. It becomes much easier to feel the pulse and to take the collection. Because the patients are lying on the bed with their hands like this, right? So you can extend it by keeping something below their hand. You can either keep a bottle of NS, that was what was available easily for us. Even here, you will see there's something kept below the hand to extend the wrist. So that those are all things that will help you with your collection and your procedure itself. Now, moving on to interpretation. Before you move on to interpretation, you need to know the normal values. These normal values have to be memorized. There is no way around it. Sometimes they're given on the reports itself, and sometimes it's not. So it's always better to know these. So your pH is from 7.35 to 7.45, PCO2 35 to 45. Now you can see 7.35 and 35. So this is the way to remember it. pH 7.35, PCO2 35 to 45. PO2 75 to 100 or 80 to 100. This varies. And bicarb 22 to 26. Oxygen saturation, the same as we check on our pulse ox. It's greater to have it above 95. Now, these next 3 slides are essentially all you need to understand about how to interpret ABGs. What do you check in an ABG? So the first thing you check is your PaO2. You check the oxygenation. If your PaO2 is between your normal range from 85 to 100, from 75 to 100 or 80 to 100, that means the oxygenation is normal. Right? We had said the ABG does 4 things: oxygenation, ventilation, acid-base balance, and respiration. So it's checking your oxygenation by directly telling you what is the partial pressure of O2. Next, you determine the pH. The pH is between 7.35 to 7.45. Right? Or the hydrogen ion concentration is between 35 to 45. Now, if your pH is below 7.35, it is acidosis. Right? Now, what acidosis means is, in your body, there is a buildup of acid that's happening, and the acid, the major acid in your body, that we assess is hydrogen ion. So you remember 11th standard chemistry, acids were HCl, H2CO3, or can anyone tell me other hydrogen acids? Right, so all your acids have that H plus ion. Whereas when you look at bases, your bases and alkalis are your CO, your carbonates. So if you have pH above 7.45, that means you have alkalosis. There is less hydrogen ion in your body. That means you have either more base or you have less acid. Okay, so these are your first two steps. Check the oxygenation, check the pH status. Next. This is the most important slide of this session. If you can understand this one slide, you have understood ABGs. Now, once you've determined the pH, you check your respiratory component, that is your PaCO2. Your PaCO2 should be normally between 35 and 45, that is 4.7 to 6 kilopascals. If it is above 45 or above 6 kilopascal, that means you have primary respiratory acidosis, right? There is something called compensation, which I'll explain in further slides, but what you need to know is either it is acidosis or it is respiratory compensation for metabolic alkalosis, right? Now, if your PaCO2 is below 35, that is below 4.7, it is primary respiratory alkalosis. हमने decide किया था acidosis, alkalosis. Now we're deciding if it's respiratory or metabolic. If it is above 45, PaCO2, respiratory acidosis, below 35, respiratory alkalosis, or compensation. Then the last step, the fourth step is determining the metabolic component. You look at the bicarb, HCO3 minus. Your bicarb should be between 22 to 26. If it is below 22, that means it's metabolic acidosis. If your pH is again in acidosis, or it is renal compensation, your kidneys are compensating. If your pH is above 7.45. Again, if your bicarb is above 26, मतलब alkalosis है. pH बढ़ रहा है, मतलब acid कम हो रहा है, मतलब alkalosis. Bicarb बढ़ रहा है, again alkalosis हो रहा है because acid कम हो रहा है. So the basic funda remains the same, right? Okay. Fifth step. What is base excess? Base excess is the amount of acid that is required to restore a liter of blood to its normal pH. Basically, what it means is it is equivalent to your bicarbonates. If you think about it in simple terms, your base excess is how much bicarb is in your body. This is what this whole paragraph explains. So your base excess, if it's excess, right? It's ज़्यादा है किसी चीज का. It is a buffer. अगर ज़्यादा है तो base excess less than -2 is metabolic acidosis. Base excess above +2 is metabolic alkalosis. Essentially, in ABG, all you need to know is CO2 is an acid, bicarbonate is an alkali. Okay? इतना समझा कि normal values क्या होते हैं, and ऊपर नीचे गया तो कब acidosis है, कब alkalosis है. Because at every step, if you get stuck somewhere, make sure you ask me something. Because उसके आगे का नहीं समझेगा if you don't understand at this point. So has everyone understood the normal values and how you determine if it's acidosis or alkalosis? Yes, no, are we sleeping? It's afternoon, I'm sure everyone's very sleepy. Yes, okay. Okay. Now what compensation means is when your body has too much acid, you want to maintain homeostasis. So your kidney will try to get rid of it. So if there is, or your lungs will try to get rid of it. There are two main things that work in maintaining your homeostasis, your kidneys and your lungs. So if you have increased bicarbonate, if you have excess acid, you have to neutralize the acid, right? If you have increased CO2, you want to increase your respiratory rate to get rid of that CO2. जब CO2 बढ़ता है, when you have increased CO2, it's called carbon dioxide retention, CO2 retention. If you ever heard your ICU residents talking, they'll say that patient is retaining CO2, carbon dioxide retention हो रहा है. That means, as we established, CO2 is an acid. उसकी body CO2 retain कर रही है, उसकी body acidosis में जा रही है. Right? Now, the way your body compensates to this CO2 retention is by your renal system excreting the acids out. Right? Similarly, when you have alkalosis, you have excess, you have decreased ventilation, you are going into CO2 washout. You're getting rid of excess CO2. That means you're losing acid and your alkali is rising. That means you're going into alkalosis. Very basic, simple formula, very easy to understand. Now, what this compensation essentially is, अगर एक खराब हो रहा है तो दूसरा ठीक करेगा, दूसरा खराब हो रहा है तो पहला वाला ठीक करेगा, right? It's like a seesaw. One or the other has to work. If both of these systems stop working, you go into multi-system failure, where you will go into either severe acidosis, severe alkalosis, because there's nothing left in your body to compensate. One by one, your organs will start shutting down, right? So this is what happens in the ICU. Why do we do the ABG repeatedly? It's because we want to check if the body is, one, getting oxygenated, two, if it is maintaining that acid-base balance. That is how we establish that the metabolic functions of the body are working properly. अगर नहीं हो रहा है, अगर acidosis बढ़ रहा है patient का, that means the patient is getting bad. If the respiratory acidosis or the metabolic acidosis is increasing, that means you're losing homeostasis. That means somewhere in the body, one of these systems have stopped working. And slowly, once your kidneys go, your lungs go, your liver goes, everything starts shutting down. Your heart will shut down. So that is why your acid-base balance is very important, especially in an ICU setup. Okay, now when you look at compensation, either your kidney is working properly so that your lung will get completely compensated, or your lung is working properly that your kidneys mess will get compensated. So अगर दोनों properly compensate हो रहा है, your pH will come as normal, but you will still have acidosis or alkalosis on the basis of your bicarbonate and PaCO2. If there is partial compensation, that means compensation takes some time to get established. Your kidney and your liver will take some time to start realizing, okay, your body is now, generating too much acid, so I need to start working, right? So this compensation takes a little bit of time to start acting. Meanwhile, you will get partial compensation, where all the three values, your pH, your bicarb, and PCO2 will all be abnormal. Okay? If it's uncompensated, your PCO2 or bicarb is normal, whereas the other is abnormal. Basically, one of the things will be normal. This, I understand, compensation is the most difficult part to understand in an ABG. Normal acidosis, alkalosis समझ में आता है. ये समझ में नहीं आता है कि क्या compensate हो रहा है. And compensation is usually the thing that determines कि which part of the body is stopped working. Is it the kidney or the lungs that have stopped working or that need help? Again, you'll get partial compensation if one of these systems is affected. अगर patient renal failure में है and उसको compensate करना है, it will be more difficult, right? Because the kidneys are not working properly, it won't be able to compensate as much. Okay. The final thing that you need to know in an ABG is an anion gap. Now, when you see an ABG report, it also shows you the electrolytes in the blood. Your anion gap is the difference between your electrolytes, your sodium, chloride, bicarb, your positive cations, the positive electrolytes, sodium and potassium, and your negative anions, that is your chloride and bicarb. So your anion gap is positives minus negative. Now, why have we only considered positive in the formula is because major positive ion in your body, major electrolyte is sodium. हम हमेशा सोडियम चेक कर लाइक सोडियम पे ज्यादा फोकस करते हैं because this is more in quantity and has a greater effect in the anion gap and in this compensation, right? So when I talk about high anion gap, that means the difference between your positive and negative ions is greater, right? Zyada difference hai. When I talk about normal anion gap, that means your difference between your positive and negative ions has not changed much. It's still normal, right? So that's what anion gap is. Very simple, positives minus negatives. Okay, getting to the fun part. Now, what are the causes of metabolic acidosis? This slide has essentially every cause that you can think of that patients will present with, and the mnemonics. So we just discussed high anion gap and normal anion gap. So the causes of high anion gap metabolic acidosis are cat mud pile. So carbon monoxide poisoning, cyanide, congenital heart disease, aminoglycosides, theophylline, toluene, glue sniffing. जो drugs लेते हैं, glue sniff करते हैं, they are the ones who will come with metabolic acidosis, high anion gap. Then methanol poisoning, uremia. Your uremia happens when your kidneys have started failing, right? So in uremia, you will get high anion gap metabolic acidosis. Then you have decay, alcoholic starvation, then paracetamol, iron, lactic acidosis, ethanol, salicylates. Salicylates are your aspirin. So again, in aspirin poisoning, you'll get high anion gap metabolic acidosis. Whereas you'll get normal metabolic acidosis in used car parts, that is ureteric diversion, small bowel fistula, extra chloride decay, carbonic anhydrase inhibitors, Addison's disease, RTA, pancreatic fistula. So this, your cat mud piles, is a more important mnemonic for you to remember for causes. Because a lot of the times when a patient presents with you, you have to take a call कि patient का ABG करना है या नहीं करना है. So you have to know कि अगर patient इस history के साथ आया है, तो I need to get an ABG done. Or if that is the relevant, like that, those are my history, that is my relevant finding, I need to get an ABG done. So I know in diabetic ketoacidosis, the patient is building more acidosis, building more acids. I will need to get an ABG done to check for their acidic levels. I know in lactic acidosis, muscle breakdown is happening, lactic acid is building up. So acid is getting accumulated in the body. So I need to get an ABG done. This is why knowing the causes is important, not because you need to remember it, you need to mug it up. Okay. Now, how do you identify on examination if the patient and history that the patient has metabolic acidosis? So these are the signs and symptoms. You'll get a headache, hyperkalemia, muscle twitching, warm skin, nausea, vomiting, diarrhea. Classically, if you remember a DKA patient, they come with these symptoms. Changes in consciousness, mental changes, post-small respiration. I sent a link on the group with videos of the different patterns of breathing, out of which you guys had answered post-small pattern. So that's seen in DKA, that's seen in acidosis, right? And the treatment for all of these is very simple. You treat the cause, automatically the homeostasis will become normal because your body will start functioning how it's supposed to. And for metabolic acidosis, you can give sodium bicarbonate or dialysis, depending on what the cause is. Okay, have you understood metabolic acidosis and its causes? Yes, then I'll move ahead. Okay. Next, metabolic alkalosis. What will be the pH here for metabolic alkalosis? Patient with metabolic alkalosis, what is the pH? More than 4.5. Are you sure? Anyone else? More than 7.5. More than 7.35. More than 7.45. Okay. Okay, we will go back to it. More than 7.45. Right? So, metabolic alkalosis. What are the causes? Now, again, logically, if the patient is in alkalosis, that means he's either losing acids or building up more bases. So when will you lose acids? If you have diarrhea, vomiting, you're losing your electrolytes, you're losing the body's acid. You'll build up more alkali. Renal causes, diuretics, low chloride intake, sweating, cystic fibrosis. I'll give you some background. Cystic fibrosis patients have a specific diagnostic test also called the sweat chloride test. They sweat a lot and usme chloride hota hai. They lose chloride ions. So again, these are where you're losing acid, building up bases. Now, other causes are electrolyte, endocrine causes. So primary hypoaldosteronism, Cushing's disease, Prater syndrome, severe hypokalemia, and some other causes are massive blood transfusions, milk alkali syndrome, bone metastasis, etc. So the major ones you need to remember, the patients that commonly come with are gastrointestinal, that are vomiting, gastric changes, chloride diarrhea, and diuretics. We take a very specific history from patients, especially older age groups, about the medications that they're on. Because a lot of the times the medicines that they're taking might precipitate these conditions. ठीक है, उनको हम पूछते हैं, especially heart failure patients को, कौन सी दवाई चालू है, क्या diuretic है, all of these details to basically prepare ourselves to assess and come to a differential. Now, the clinical features, again, confusion, dysarrhythmia, compensatory hyperventilation, dizziness, nausea, vomiting, anxiety, seizures. Because you have less serum calcium, you will get tremors, hypocalcemia में जो अपना tetany होता है, right? Spasm, carpopedial spasm, muscle cramps, etc. Okay. Again, treat the cause, the patient will get better. Respiratory acidosis. Now, the causes of respiratory acidosis, again, very simple to understand. We know carbon dioxide is an acid. So if your lungs are not working, they're not able to remove the carbon dioxide from your body. So any cause of hypoventilation, in which conditions will you see hypoventilation? Where will the respiratory rate be less? Anyone knows when do we get hypoventilation? Opium poisoning, morphine poisoning, high altitude. Okay. High altitude may, initially may be less, but then you'll start hyperventilating to compensate. Anything else more common? Emphysema, yes. COPD, respiratory condition, where they're not able to breathe. Foreign bodies, yes, especially in children. Anything else? Obesity. Okay, so I'll give you a very simple way of thinking about it. You have your lung, you have your chest wall, right? अगर lung में pathology है, तो क्या conditions हैं? हमारे COPD, asthma, basically airway problems, right? Then you have your chest wall. Anything that stops your lung from expanding. That if you cannot open your lungs, if you can't breathe properly, that means you won't be able to ventilate enough. So lung pathologies, then you have chest wall pathologies. Chest wall pathologies, scoliosis, obesity, too much fat, not able to breathe properly, pneumothorax, exactly. So if you think about it, if you think about anything in medicine, according to the basic anatomy and physiology, it gets much easier to remember and understand. ठीक है, लंग में प्रॉब्लम, अगर हाइपोवेंटिलेशन है, लंग में प्रॉब्लम है, लंग CO2 नहीं निकाल रहा है, एसिड बिल्डअप हो रहा है, रेस्पिरेटरी एसिडोसिस, वेरी सिंपल. चेस्ट वॉल में प्रॉब्लम है, स्कोलियोसिस है, उसको ओबेसिटी है, ट्रॉमा टू द चेस्ट, राइट, pneumothorax, all of that. Okay, so again, not able to ventilate properly, hypoventilation. Drugs, anything that depresses your respiratory center. So as you guys mentioned, opium poisoning, morphine, depressants bolte hain. Morphine is a depressor. It decreases your respiratory rate, it decreases your heart rate, right? So your basic anatomy was lungs, chest wall. Your physiology is respiratory center से impulse आता है, इसलिए हम ventilate करते हैं, right? And अपना COPD and everything. Okay. So if you have hyperventilation, you will have hypoxia. So we're checking the oxygenation on your ABG. The PaO2 will be less. Rapid shallow respiration. PP will be low. Skin will be pale blue. Headache, hyperkalemia, dysrhythmias. If you're thinking of respiratory acidosis, think of a COPD patient. Those blue bloaters, pink puffers, hum nahi padhte. Those patients will have acidosis, drowsiness, disorientation. Why will you have drowsiness? Because your oxygenation is less. Your brain is getting less oxygen. Then you have muscle weakness, hyperreflexia, right? Okay. So as you can see, respiratory depressants, again, anesthesia, because what your anesthetics ka side effect is, it depresses your respiratory center. It makes you sleepy, right? An anesthetic will put you off to sleep. So वो तुम्हारा respiratory center भी depress कर सकता है. Then your drug overdoses, increase intracranial pressure. So head injury. If your head injury has a brain bleed, it will depress the respiratory center and cause hyperventilation. So these patients need to be intubated, right? A lot of the times you'll get a head injury patient, severe bleeding, sudden collapse of jayega. So you need to make sure they're ventilated, because if the respiratory center gets involved, they'll collapse and die immediately. Again, then you have alveolar capillary diffusion. Again, your lung pathologies, pneumonia, COPD, pulmonary embolism, ARDS. Okay. Respiratory alkalosis. Now the exact opposite. When you're breathing too much, you have too much hyperventilation हो रहा है, you're washing out your CO2. सारा CO2 बाहर निकाल दिया तुमने बॉडी का, एसिड है ही नहीं, बेस ज्यादा बढ़ गया, too much base. So what will be the causes? Anxiety. Patients will come to you with chronic anxiety disorder, panic में आ रहा है patient, severe hyperventilation. They will go into alkalosis. Then stroke patients. Again, they are hyperventilating, they will wash out the CO2. Ischemia, tumors, fever, very high grade fever, you will see the patient will be tachycardic and hyperventilating. Drug induced, salicylates, anaphylaxis, progesterone in pregnancy. Okay? Then you have peripheral stimulation. So hypoxemia, high altitude. When you mentioned height, it's difficult to breathe because your partial pressure, उस air में, जैसे जैसे height पे जाते हैं, air का oxygen saturation कम होते जाता है because pressure कम हो रहा है. So because height पे oxygen कम है, your body needs that oxygen. So it ventilates, it increases the respiratory rate to take in more oxygen. Okay? So it hyperventilates. You will go into alkalosis and not acidosis. Then you have what will eventually happen is your body will get tired. Hyperventilate कब तक करोगे? Eventually your body will go into alkalosis and start getting tired. That's when you go into hyperventilation. When your body eventually starts shutting down, gives up, and then you go into hyperventilation. So initially hyper, later hypo. Yeah, it's very interesting. If you read about high altitude medicine, it's an entire branch in itself. After it's a specialty where you have certain conditions called high altitude sickness, serum sickness. जो mountain climbers जो होते हैं ना, उनमें बहुत commonly दिखता है, जो trekking करते हैं high altitude पे, they get altitude sickness and haze and other related lung conditions. So things like that. Again, congestive heart failure, asthma, pulmonary embolism. So you see how a pulmonary disease can lead to either acidosis or alkalosis, depending on what is happening to the ventilation. Right? Unknown mechanism, sepsis में patient जा रहा है, hyperventilate कर रहा है, CO2 wash out हो रहा है. Same. Again, iatrogenic is ventilator induced. If your ventilator settings are not proper, you have put the ventilation settings as too high. The patient is mechanically being ventilated, but they're ventilating it too much. So alkalosis में जा रहा है. Again, what are the clinical features? Seizures, deep breathing, hyperventilation, tachycardia, hypokalemia, tingling numbness. lethargy, confusion, lightheadedness, nausea, vomiting, right? So since you mentioned high altitude, respiratory alkalosis में जब patient जाने लगते हैं high altitude के, they start getting nausea and vomiting, they get lightheaded, उनको सर में से सब धुंधला लगने लगता है, they start hallucinating, things like that. Okay, we're done. So ABG essentially is very easy as long as you know these 4 slides. ठीक है, थोड़ा logic and थोड़ा formula लगा के you can figure out any ABG. Okay, case 1. A 33-year-old female was brought to the casualty, known case of anxiety disorder with complaints of palpitation, sweating, difficulty in breathing. pH is 7.55, PaO2 is 11, PCO2 is 3.1, bicarbonate is 20. What is the ABG interpretation? Metabolic alkalosis, okay.
Metabolic alkalosis.
Metabolic alkalosis. Anyone else has a different answer? Does everyone agree it's metabolic acidosis? The respiratory alkalosis. Okay, we have a metabolic alkalosis, we have a respiratory alkalosis, we have a metabolic acidosis. 4 option hai. Someone can answer the last one also. Anyone else wants to take a try? Let's see if we can get a majority. Okay, what we'll do is we'll take it step by step. What is the pH? Just look at the pH and tell me if it is acidosis or alkalosis. Utna establish karo maine.
मैम अल्कोहल और पार्शियल प्रेशर कार्बन डाइऑक्साइड का 3.1 है तो मींस ये रेस्पिरेटरी alkalosis हो जाएगा.
Okay, fine, great. Alkalosis. So everyone agrees it's alkalosis. ठीक है? PaO2 is 11. That means the oxygenation of this patient is normal. PaCO2 is 3.1. ठीक है? 3.1 है. That means it's less than 4.6. What does this mean? I'll go back to the slide. If PaCO2 4.7 से कम है, that means either it's respiratory alkalosis or it is respiratory compensation for metabolic acidosis. 2 आंसर हो गए अपने पास, 2 possibilities है. ठीक है? Now to eliminate between these two, या तो उसको respiratory alkalosis है या फिर compensation है. You look at the bicarb. अगर bicarb normal है तो primary respiratory alkalosis. अगर bicarb कम है तो compensation है. If we go back to the case, what is her bicarb? Bicarbonate is 20. Bicarbonate is less, right? So what is it? What is it? We have 2 options, either respiratory alkalosis or respiratory compensation for metabolic acidosis. क्या हुआ? दोनों में से कौन सा? Compensation, right? Respiratory compensation. Good. So if you go step by step, pH is 7.55. I know it's a tough ABG. See, a lot of the times you'll get ABGs like this, which don't make sense. pH 7.55 है, alkalosis भी है, and compensation भी है. So this happens. This is very common. This is why we say ABGs are difficult to do because you can get both. ठीक है? Either ways, what you're trying to understand is alkalosis हो रहा है या फिर compensation है. ठीक है? चीज तो वही हो रही है. या तो अब तुम हिस्ट्री पे जाओ इसके. उसके हिस्ट्री पे क्या है? अगर तुम्हें एबीजी का इंटरप्रिटेशन वेग आया है, एंड दिस हैपेंस अ लॉट, यू विल गेट अ लॉट ऑफ एबीजीज वेयर यू विल ईदर बी कंफ्यूज, या तो प्लेन एसिडोसिस अल्कलोसिस है या कॉम्पेंसेशन है. व्हाट यू कैन डू इज लुक एट द हिस्ट्री, because you know before all of these investigations the first thing you saw was history. She is coming with anxiety disorder, palpitation, sweating, difficulty in breathing. What is it likely to be? Respiratory rate 33. What would you go with? Hyperventilation. अगर hyperventilation है तो क्या मतलब है इसका? Respiratory alkalosis. Right, you're likely to go with a respiratory alkalosis because she's hyperventilating and her oxygenation is still normal. Okay, so this is another way. This is the essentially, if you don't do cases on paper, theory समझ में आ जाता है, ये ऊपर है ये नीचे है. But unless you start doing cases, you will not be able to understand how to correlate your lab findings with your history clinically. ठीक है, समझा? Have we understood what the difference between compensation and straightforward acidosis alkalosis is? This is why no one will ever come and give you just an ABG report and be like, बताओ क्या है? Because every ABG report has possibilities. कि या तो compensation हो सकता है या direct acidosis alkalosis हो सकता है. ठीक है? Did you guys understand this case? Should I move ahead? And this is the reason why I put this as the first case. Yes, no, confused. Should I explain again? Clear, great. Okay. Next one. 44-year-old male chronic smoker came to the casualty with complaints of shortness of breath since last night. pH is 7.3, PaO2 is 8, PCO2 is 7, bicarbonate is 23. What do you think it is? Okay, Prashant says respiratory acidosis. Anyone else? Rakshada is saying respiratory acidosis. Priya is saying respiratory acidosis. Everyone agrees respiratory acidosis. No one wants to try anything else. Okay, we've established acidosis है. Acidosis, alkalosis is the easiest to understand. pH देख के. उसके बाद respiratory, how did we decide? Why is it not metabolic? CO2 retention, right? With no compensation, right? Now you've understood why it's not compensating, because your pH is deranged, right? And CO2 retention है. So it's respiratory acidosis. Good. Case 3. 22-year-old male, known type 1 diabetic, insulin therapy, history of vomiting, abdominal pain, palpitations. To be honest, itne history se you should know what the pH, your ABG interpretation is going to be without even seeing the pH values. What is it? DKA, good. DKA में क्या आएगा pH पे?
Metabolic acidosis.
Great, exactly. So you have to understand your greatest strength is your history and your examination, not your investigation. ठीक है, तो इसके पहले ही तुम्हें पता होना चाहिए कि ABG पे क्या आएगा. pH 7.15, bicarb 18. What would you like to give to treat the acidosis?
We give Lasix for flush out the acid. है ना, Lasix से देखो. हाँ, Lasix से देखो.
Are you sure? Lasix भी दे रहे हो उसको. Lasix तो diuretic है. फ्यूरोसेमाइड
मैम लैसिक्स भी देते हैं और साथ में आईवी फ्लूइड भी देते हैं, आईसीयू में था, मतलब दोनों को
तो
बैलेंस करते होते हैं, क्योंकि
हाँ
डीके में उनको डिहाइड्रोजन वो भी होता है ना, डिहाइड्रेशन भी होता है, तो इसके लिए देते हैं। हाँ, आईवी फ्लूइड मस्ट रहता है और साथ में लैसिक्स भी देते हैं, ताकि उनको मतलब फ्लूइड रिटेंशन वगैरह ना हो, साथ में पल्मोनरी एडिमा, तो दोनों
राइट
देते हैं।
राइट। तो योर फर्स्ट आंसर इज आईवी फ्लूइड्स नॉट लासिक्स। तुम किसी को लासिक्स बोलोगे पेशेंट मर जाएगा, डीके के पेशेंट को लासिक
हाँ,
दे रहे हैं। राइट, यू आर राइट, द लॉजिक इज करेक्ट कि तुम हाइड्रेट कर रहे हो पेशेंट को, एनएस दे रहे हो, लासिक्स दे रहे हो फ्लूइड ओवरलोड प्रिवेंट करने के लिए, and you'll give sodium bicarbonate. Sodium bicarbonate to correct the metabolic acidosis.
एसिडोसिस।
Right. You give NS, insulin, सोडा बाइकार, पोटेशियम। ठीक है, ये डीके के 4 चीजें होती है मैनेज करने के लिए। फ्लूइड विद लासिक्स, डीके, सोडा बाइकार, इंसुलिन, पोटेशियम। ठीक है, ओके। केस 4, 63-year-old male was brought unconscious to casualty and resuscitated. उसने हिस्ट्री दिया सिवियर डायरिया एंड वॉमिटिंग फॉर 4 days, pH 7.22, बेस एक्सेस -14. व्हाट इज योर इंटरप्रिटेशन?
मेटाबॉलिक 7, हाँ, एसिडोसिस में जा रहा है।
ओके, एनीवन एल्स हैज अ डिफरेंट आंसर?
मेटाबॉलिक एसिडोसिस, मेटाबॉलिक
ओके, एक मेटाबॉलिक एसिडोसिस, एनीवन एल्स वांट्स टू? नॉर्मल anion gap. Anion gap has not been given here. This is all the information you have. But it's a good question. You should be asking this. Where is the anion gap? Where are the electrolytes? What I'll do is on the group, I'll send you a few ABGs, real life ABGs, जो मेरे पास patients के हैं, उसमें see all the information that's given, the electrolytes, the PaO2, PCO2. We know that we want acidosis, alkalosis, but the machine gives you a lot more information, and we use that interpretation for further assessment. तुम्हारे लेवल पे इतना बहुत है, तुम्हें compensation तक समझ आ गया, is well and good. Okay, what is the final answer? I heard metabolic acidosis. Anyone else? Final answer. And I'm moving on to the last case and we'll end. Nobody? Metabolic acidosis. Okay. Why is it metabolic?
Thus, there is severe diarrhea na, and vomiting history. So the loss.
Acidosis होगा.
Yes.
What were the causes of metabolic acidosis? Where is vomiting and diarrhea? It's very cool to confuse you guys. If vomiting or diarrhea तो नहीं है acidosis में. That's not why it's metabolic acidosis. It's metabolic acidosis on the ABG. Vomiting or diarrhea तो alkalosis में. Why did he ask me the anion gap? Because it doesn't match the history. Sorry. Metabolic acidosis तुम्हें ABG में बोल रहा है, but severe diarrhea and vomiting इतना ही history दिया है. Will you want to ask something more? Do you want to take further history patient का? 63-year-old male. We established metabolic acidosis. Everyone agrees it's metabolic acidosis. Is everyone in agreement that it's metabolic acidosis or not? ABG के हिसाब से acidosis है कि नहीं है?
मैम पीएच का मैं तो एसिडोसिस तो मेरे आवाज
Yes, okay. Everyone agrees it's metabolic acidosis, but you haven't determined the cause. तुमने पेशेंट का सिर्फ इतना हिस्ट्री दिया कि उसको डायरिया एंड वॉमिटिंग है. वो डायरिया एंड वॉमिटिंग का कॉज क्या है? Right? So these patients, when you're doing an ABG and taking the history, if your investigation and your history is not matching, that means you need to ask more. कहीं तो कुछ गड़बड़ है, because your body will not lie. Patient was resuscitated, yes. Okay. So what was the cause of the diarrhea and vomiting? We don't know. Maybe it was a medication. Maybe it was uremia. Maybe वो kidney failure में है. Whatever it is. So you have to understand, if your history and your investigation is not matching, something has gone wrong somewhere. Okay? Again, do not blindly depend on either of them. Maybe he was in shock. Exactly. You don't know what precipitated the acidosis. You just know ABG पे acidosis आया. ठीक है? मतलब तुम्हारी हिस्ट्री में और कुछ है, कुछ गड़बड़ है. ठीक है? Case 5. 44-year-old male brought to the casualty with history of ingestion of unknown medication. Complaint of chest and abdominal pain with palpitation, nausea, altered mental status. pH 7.22, PaCO2 3, bicarbonate 18. What is the ABG interpretation? I just wanted to tell me ABG का क्या interpretation. I'm not asking what the diagnosis is. Anybody?
मैम मेटाबॉलिक एसिडोसिस विद रेस्पिरेटरी alkalosis compensation.
Okay. Priya says metabolic acidosis. Is there any compensation? Metabolic acidosis. ये रेस्पिरेटरी कॉम्पेंसेशन क्यों बोला था? कॉम्पेंसेट कहाँ हो रहा है? With partial respiratory compensation.
मैम पार्शियल प्रेशर CO2 का कम है.
Partial pressure CO2 का कम है. Okay. Right. So you guys are getting better at this. Much better than I expected after one session. So that's good. Basically, what you need to keep in mind is every ABG will have 8 possibilities. Okay, so you have to figure out acidosis, alkalosis, respiratory, metabolic, then compensation or not. Okay. अब यहाँ पे pH compensated नहीं है, but अपना CO2 3 है. I'll go back to that slide if you guys want to see. Okay, PCO2 bicarb is decreased. pH is less. You have clear cut acidosis. इतना तुम establish कर सकते हो. तुम्हारा first step हो गया. Then it's pretty easy. Once you know acidosis है, then you check the bicarb. Bicarb was 18. Okay, bicarb is less than 22. Either it's metabolic acidosis or it's renal compensation, or it's partial compensation. Okay, have you guys understood what I'm trying to explain? Did you guys also understand how in real life scenarios, if the history and your investigation is not matching, you need to take further history, or you need to figure out what has gone wrong somewhere, and that if your lab investigations are not clear or not making sense, that means, again, your history is your biggest clue. Okay? Or if the patient, sometimes it may be the other way around, the patient might be hiding something. अब ये अंकल जो आए हैं, unconscious 63-year-old uncle, maybe he is being poisoned, right? And he doesn't know, or something like that. The patient is an Alzheimer's patient. He doesn't remember what medication he's taken, so his history is not reliable. So that's when your investigation becomes more important. So you have to understand, in real life situations, this is what comes with clinical acumen. तुम जितने ज्यादा पेशेंट देखोगे, तुम्हारा ये स्किल बढ़ता है, understanding how to move forward, right? This is what will only come after years and years of seeing patients and understanding cases, understanding case scenarios. Okay. Now, there are certain calculators available online that basically help you do what you just did mentally. जो तुमने 6 steps में किया, that you can directly add to calculators and they will give you the acidosis and alkalosis. But they all come with a disclaimer that it has to be clinically correlated. It has to match your history. That is what I was trying to explain to you. And if your history and investigation is not matching, all of these calculators are waste, right? So this is why, as a physician, your skill takes over a calculator. So always remember this. Okay, that's it. I will share a few ABGs on the group as well, so you can see what a real life ABG looks like and what interpretations you can get from it. That's it for today's session. Thank you for joining.